Welcome to Critical Care Simplified. In this review, we are going to walk through the basics of ECG interpretation for new ICU nurses. If you are new to critical care, the monitor can feel intimidating at first. There are numbers, waveforms, alarms, and sometimes several people asking, "What rhythm is that?" The goal of this video is not to turn you into a cardiologist in 10 minutes. The goal is to give you a safe, repeatable approach, identify the major parts of the ECG, estimate the heart rate, assess the rhythm, recognize common patterns, and know when to escalate care. As you watch, remember one key principle. The monitor gives you information, but the patient gives you context. By the end of this lesson, you should be able to do 4 things. First, identify the major ECG components, the P wave, PR interval, QRS complex, ST segment, and T wave. Second, calculate heart rate using quick bedside methods. Third, recognize common ICU rhythms, including normal sinus rhythm, sinus bradycardia, sinus tachycardia, atrial fibrillation, SVT, ventricular tachycardia, ventricular fibrillation, asystole, and PEA. And fourth, recognize when a rhythm needs immediate escalation. ECG interpretation is a skill that improves with repetition. The more consistently you use the same framework, the faster and safer you become. ECGs matter in the ICU because rhythm changes can be early warning signs of deterioration. A rhythm strip may reveal a life-threatening arrhythmia before the patient loses a pulse. It may show clues related to electrolyte problems, such as potassium or magnesium imbalance. It may also reflect medication effects, ischemia, hypoxia, pain, fever, bleeding, anxiety, or shock. For nurses, ECG interpretation is not just an academic exercise. It helps guide real bedside action, assess the patient, verify the rhythm, notify the provider or rapid response team when needed, prepare for interventions, and follow your unit protocols. In critical care, rhythm recognition supports clinical judgment, but it never replaces it. Let's start with the basic parts of the ECG waveform. The P wave represents atrial depolarization. In simple terms, it is the electrical signal moving through the atria. The PR interval represents the time from the start of atrial activity to the start of ventricular activity. The QRS complex represents ventricular depolarization, which is the electrical activation of the ventricles. Because the ventricles are larger muscle chambers, the QRS is usually the most visible part of the rhythm strip. The ST segment is the period after ventricular depolarization and before repolarization is complete. The T wave represents ventricular repolarization. When you look at a rhythm strip, do not try to memorize every detail at once. Start by asking, do I see P waves? Are they related to the QRS complexes? Is the QRS narrow or wide? Is the rhythm regular? These questions create structure. Now, let's estimate the heart rate. One quick method is the 300, 150, 100, 75, 60, 50 method. Find an R wave that lands on a bold line, then count the large boxes to the next R wave. One large box is about 300 beats per minute. 2 large boxes is about 150. 3 is about 100, 4 is about 75, 5 is about 60, and 6 is about 50. This method works best when the rhythm is regular. If the rhythm is irregular, the 6-second method is often more useful. Count the number of QRS complexes in a 6-second strip and multiply by 10. For example, if you count 8 QRS complexes in 6 seconds, the estimated heart rate is about 80 beats per minute. Rate is important, but rate alone is not the whole story. Always connect the number to the patient's blood pressure, mental status, oxygenation, symptoms, and overall condition. A simple rhythm assessment framework can prevent confusion. Step 1. assess regularity. Are the R waves evenly spaced, or is the rhythm irregular? Step 2. Look for P waves. Is there a P wave before every QRS? Is every P wave followed by a QRS? Step 3. Evaluate the PR interval. Is it consistent? Step 4. Look at the QRS width. A narrow QRS usually suggests the impulse is traveling through the normal ventricular conduction system. A wide QRS may suggest ventricular origin or abnormal conduction, and in an unstable patient, it deserves urgent attention. Step 5. Assess the patient. Are they awake, hypotensive, short of breath, having chest pain, losing pulses? This final step is essential. You are not treating a rhythm strip in isolation. You are caring for a person. Normal sinus rhythm is the baseline rhythm we compare many others against. In normal sinus rhythm, the rate is typically 60 to 100 beats per minute. The rhythm is regular. P waves are present and consistent, and each P wave is followed by a QRS complex. Intervals are within normal limits. For a new ICU nurse, normal sinus rhythm is a good place to practice the framework. Ask yourself, is it regular? Do I see a P wave before every QRS? Is the QRS narrow? Is the rate between 60 and 100? If yes, the strip likely fits normal sinus rhythm. But even when the rhythm is normal, continue assessing the patient. A normal rhythm does not automatically mean the patient is stable. Sinus bradycardia is a sinus rhythm with a rate less than 60 beats per minute. You may still see regular P waves before each QRS, and the rhythm may look organized. The key question is not only is the heart rate low, the key question is the patient tolerating it? Some patients may have a low resting heart rate and be completely stable. Others may become hypotensive, dizzy, altered, short of breath, or poorly perfused. In the ICU, bradycardia can be related to medications, conduction disease, increased vagal tone, hypoxia, or other clinical problems. Your nursing response begins with assessment. Check the patient, check the blood pressure, verify the rhythm, review medications, and escalate if the patient is symptomatic or unstable. Sinus tachycardia is a sinus rhythm with a rate greater than 100 beats per minute. The rhythm is usually regular and P waves are present before the QRS complexes. In the ICU, sinus tachycardia is often a sign that something else is happening. Common causes include pain, fever, hypovolemia, anemia, anxiety, hypoxia, sepsis, or medication effects. The important bedside habit is to search for the cause instead of simply focusing on the number. Ask, is the patient febrile? Are they in pain? Are they bleeding? Is the oxygen saturation dropping? Are they becoming septic? Sinus tachycardia can be the body's compensatory response. Treating the underlying cause is often the priority. Atrial fibrillation is commonly described as irregularly irregular. That means the R to R intervals are not consistent and there is no repeating pattern. You also do not see distinct, consistent P waves before each QRS. Instead, atrial activity is disorganized. In the ICU, atrial fibrillation may be chronic, new onset, controlled, rapid, stable, or unstable. Your assessment should include the rate, blood pressure, symptoms, perfusion, anticoagulation considerations if relevant, and possible triggers such as infection, hypoxia, electrolyte imbalance, or postoperative stress. For rhythm recognition, remember two big clues: irregularly irregular rhythm and no distinct P waves. Then immediately connect the rhythm to the patient's condition and your unit's escalation pathway. SVT, or supraventricular tachycardia, is usually a regular, narrow complex tachycardia, often with a rate greater than 150 beats per minute. P waves may be difficult to see because the rhythm is moving so fast. At the bedside, SVT can look dramatic because the rate is high, and the patient may feel palpitations, chest discomfort, shortness of breath, dizziness, or anxiety. Your first priority is to assess stability. Check blood pressure, mental status, chest pain, oxygenation, and signs of poor perfusion. A stable patient with SVT may be managed differently than an unstable patient. Follow your facility protocols and provider orders. The rhythm recognition takeaway is this: regular, narrow, fast, often over 150. Ventricular tachycardia is a wide, complex tachycardia. In the ICU, this rhythm should immediately get your attention. The critical nursing action is to check for a pulse and assess the patient. VT with a pulse and VT without a pulse are not treated the same way, so pulse check and patient assessment are essential. A patient in VT may be awake but unstable, or they may have no pulse and require immediate resuscitation. Wide complexes, rapid rate, and clinical instability are danger signs. If you see a wide complex tachycardia on the monitor, do not stand at the central station debating the strip. Go to the patient, check responsiveness and pulse, call for help, and follow ACLS and unit protocols. Ventricular fibrillation is a chaotic rhythm. There is no organized ventricular contraction, and the patient will not have an effective pulse. This is a life-threatening emergency requiring immediate defibrillation and high-quality CPR according to ACLS protocols. For new ICU nurses, the rhythm recognition point is that VF does not look organized. You do not see regular QRS complexes marching across the strip. Instead, the waveform is chaotic and disorganized. But again, always confirm clinically. If the monitor looks like VF, assess the patient, call for help, start the emergency response, and prepare for defibrillation per protocol. Time matters. Asystole and PEA are both cardiac arrest rhythms, but they are different. Asystole is the absence of meaningful electrical activity, often appearing as a flat line. Before calling asystole, confirm the rhythm. Check the patient, check leads and connections, increase gain if appropriate, and verify in more than one lead according to your unit practice. PEA, or pulseless electrical activity, means there is electrical activity on the monitor, but the patient has no pulse. In both situations, the focus is immediate resuscitation according to ACLS and local policy. The nurse's role includes recognizing the emergency, calling for help, beginning high-quality CPR when indicated, preparing medications and equipment, documenting, and supporting the team. Here are a few ICU tips to bring everything together. First, assess the patient first. If the monitor alarm sounds, look at the patient, not just the screen. Are they awake, breathing, perfusing? Do they have a pulse? Second, check electrolytes. Potassium, magnesium, calcium, and acid-base changes can all affect cardiac rhythm. Third, review medications. Vasopressors, antiarrhythmics, beta blockers, sedatives, and many other drugs can influence rate and rhythm. Fourth, compare with prior rhythm strips when available. Is this new or baseline? Fifth, know when to escalate. If the patient is unstable, symptomatic, pulseless, or the rhythm is potentially lethal, call for help early. Strong ICU practice is built on pattern recognition plus patient assessment. Let's summarize. ECG interpretation starts with a consistent framework. Identify the ECG components, estimate the rate, ask whether the rhythm is regular, look for P waves, evaluate the PR interval, and assess the QRS width. Then connect what you see on the strip to what you see in the patient. Normal sinus rhythm is regular, with a rate of 60 to 100. Sinus bradycardia is under 60, and the key question is perfusion. Sinus tachycardia is over 100, and the key question is cause. Atrial fibrillation is irregularly irregular, with no distinct P waves. SVT is usually regular, narrow, and fast. Ventricular tachycardia is wide and dangerous, so check for a pulse. Ventricular fibrillation requires immediate emergency response. Asystole and PEA require confirmation and ACLS-based care. Most importantly, treat the patient, not just the monitor. If this video helped you, please like the video and subscribe to Critical Care Simplified for more critical care nursing reviews.